Hi class, this lecture is going to talk about hypertensive disorders in pregnancy. You should have the PowerPoint slides located in Canvas. Hopefully you've printed them off to take notes. Please take notes as we go through, write down any questions that you may have, and please feel free to email me or let me know what your questions are next time we meet. Hypertensive disorders in pregnancy is one of our top 4 leading causes of maternal morbidity and mortality in the U.S. There are different categories. We have gestational hypertension, we have preeclampsia or eclampsia, we have chronic hypertension, and then we have preeclampsia superimposed on chronic hypertension. I know all of those sound like foreign terms to you, but we're going to break them down in this lecture. Gestational hypertension develops for the first time after 20 weeks gestation. So if a patient has had hypertension before 20 weeks, it's just hypertension. If they have hypertension after 20 weeks gestation, now without the presence of protein in their urine, it is now defined as gestational hypertension. And that definition is a systolic blood pressure of greater than or equal to 140 over greater than or equal to 90. It may resolve spontaneously after birth or become transient. And if it continues 12 weeks after delivery, it is then labeled chronic hypertension. It may develop into preeclampsia or eclampsia syndrome. We're going to monitor protein in the urine and their blood pressure with every prenatal visit every time we see this patient. Just like with gestational diabetes, we're looking for protein in the urine for gestational hypertension if it's developing into preeclampsia. We may prescribe antihypertensives depending on how high the blood pressure is. Preeclampsia or eclampsia. Preeclampsia is blood pressure, again, 140 over 90 with protein in the urine. So it has the protein in the urine as well. Usually develops after the 20th week of gestation. It only becomes eclampsia if we have seizure activity or coma along with it. Okay, so eclampsia is seizure activity. It may develop gradually or appear suddenly without warning. That's why we do a urine dip for protein every prenatal visit, every time. The underlying cause is unknown for this. We don't know why people develop it, but our risk factors are a family history of preeclampsia, nulliparity, meaning they've had no births before, a pre-existing medical condition, such as chronic hypertension, lupus, renal disease, or diabetes, obstetric complications, if they have multiples, a molar pregnancy, erythroblastosis fetalis, or if they're younger than 20 or over 35, those two bookends of pregnancy. Younger than 20 or older than 35 it puts you at risk for preeclampsia. What can happen? There are severe effects that can happen to the baby and the patient, the fetus and the patient. There's no preventative therapy known to date. Some providers will put their patients on baby aspirin to help with symptoms or to help with the preeclampsia, but there's no preventative therapy known to date. It's unable to predict. We do careful monitoring and early detection through regular prenatal care, blood pressure monitoring, and urine for protein, right? Urine dip for protein. The primary underlying development is generalized vasospasm and heightened neurosystem. Clinical manifestations, again, elevated blood pressure greater than 140 over 90 with proteinuria. It's classified as mild or severe. continued elevation of blood pressure and proteinuria, nervous system irritability, which leads to our seizures, hyperactive deep-tended reflexes, so they have a +3, +4 deep-tended reflex when we check. Clonus. Clonus is where you push on their foot or their wrist or hand very quickly, and their foot or their hand will tick back at you. That's called clonus. We count how many times it ticks back at you to see how irritable the nervous system is. They'll have severe headaches. This headache doesn't go away with Tylenol. And I say Tylenol because we don't use ibuprofen after a certain number of weeks of pregnancy. They'll have blurred vision or double vision or seeing spots before their eyes, nausea, and pain in the epigastric region, the right upper quadrant where the liver is. Again, seizures defines eclampsia. With seizures, we have potential complications for aspiration. With these patients, if they're seizing, of course, we're going to turn them on their side just like any other patient. Have their head facing down to help all of the secretions, gravity pull the secretions out. It can lead to cerebral hemorrhage, stroke, hepatic rupture, abruptio placenta, so the placenta can separate from the uterine wall, which can make the baby and the mama bleed out. Fetal compromise can decrease blood flow through the placenta, causing hypoxia of the fetus, and then death of the woman or fetus can happen as well. Mom remains at risk for seizure activity in the postpartum period. HELP syndrome can develop. This is severe preeclampsia. It's a severe complication of preeclampsia. The acronym stands for hemolysis, elevated liver enzymes, and low platelets. If we have these findings, it's called HELP syndrome. It's typically seen with severe preeclampsia, and symptoms are epigastric pain and tenderness, nausea and vomiting, visual disturbances, and headache that's not relieved with Tylenol. It may be mistaken for flu symptoms or other viral illnesses, making the patient not seek care immediately. Treatment is really delivery of the baby. However, even if they didn't have preeclampsia in pregnancy, they can develop preeclampsia about 2 weeks after pregnancy, so we need to watch those at high risk closely. If it's mild preeclampsia, we have them on bed rest, limited stimulating environment, so dim the lights, not a whole lot of TV and visitors. We have them do fetal kick counts. You guys all know fetal kick counts are 10 movements, doesn't have to be kicks, in 2 hours to determine fetal well-being at home. We can do an amniocentesis to see if the lungs are mature enough for delivery if they're preterm. We can give some hypertensive medications, although it's controversial. We can prevent seizures with bed rest, quiet room. If we think we're close to seizure, we could give magnesium sulfate in an IV drip, large dose of magnesium, but we would want to monitor for signs of toxicity, which would be reduced reflexes, right? When we use magnesium sulfate for either preterm labor or preeclampsia, we give a large bolus. This can make the patient feel very hot, very stuffy, very uncomfortable, and then we'll reduce the drip after that bolus. Again, they'll feel stuffy, hot. They really don't feel good on magnesium. Decreased reflexes. We're going to monitor those reflexes very frequently. And if we're going to induce labor, we will use oxytocin to induce labor. But if you think about oxytocin makes the uterus contract, whereas magnesium sulfate makes the uterus relax. And so they're kind of going head-butting each other. and it can make induction of labor pretty difficult. Nursing care, we're going to do frequent vital signs. We're going to assess the lungs to see if they're starting to get fluid on the lungs. We're going to monitor their weight, make sure they're not retaining fluids. We're going to check their reflexes. If they're preeclamptic, they're going to have hyperreflexia. If we're monitoring for magnesium sulfate, we're monitoring for hyporeflexia. What is the antidote for magnesium sulfate? Give you a second to think about it. It's calcium gluconate. So we're going to have that available and ready to go if we are becoming mag toxic. Let's see. We're going to inform the patient of the reasons for the treatment, educate her on what's happening, provide emotional support. A lot of these patients feel like this could be their fault, and it really isn't. So we've got to provide emotional support. Anything that puts our mamas at risk, they feel like it's maybe their fault, they did something wrong. We're going to put them on bed rest. We're going to lie them on their side. Left side is best, right? But right side is okay too. We're going to do strict monitoring of eyes and nose. Make sure they're eating adequately. Support their psychosocial needs. And we're going to keep watching them closely in the postpartum period, the post or postpartum period. And then also, if they were on magnesium sulfate in labor, our baby is going to get that medication too. It does cross the placenta, so we're going to watch that baby closely. Maybe have NICU at the delivery to make sure baby's doing okay, and monitor for side effects of the magnesium. I hope you all enjoyed that lecture and it's given you a clearer picture as to the hypertensive disorders in pregnancy. If you have any questions, again, please feel free to email me or let me know next time we see each other. Have a great day.